First of all, I want to welcome everyone to the Anatara Medicine podcast. This is a podcast we just sort of started to get me into fireside chats with outstanding experts across a wide variety of fields. Today, I have the luxury of talking to a good friend, Dr. Paul Anderson, who's a very senior naturopathic physician in the United States, a leader, I think, internationally, written many books on oncology, and now I think veering into mitochondrial function and all the fancy terms that will come out of the discussion today as it relates to COVID, but quite a fusion between an academic, someone's trained like myself in academic medicine, but putting numbers and observations down and publishing, and have done an outstanding job in training MDs like myself in naturopathic forms of thinking and principles, and then backing it up with experience. I believe you still have your very large and successful clinic in Seattle. Correct, Paul?
Yes, in different format than it was before COVID, but yeah, everybody is still there taking care of patients, and we're just sort of set up a little different than we used to be.
Yeah, but you've accumulated a tremendous amount of information, and I know you've been involved in NIH studies on integrative medicine and oncology, and there's so few grants given in that direction that you made the most of it, and that field, of course, is just absolutely necessary to exist, in essence, in parallel to allopathic forms of oncology. But today, to me, the reason I wanted to get you and your mind on the podcast today is because the way you think, and I think that if you have something that makes everything worse, in this case a virus, you can learn about a lot of things that are basically fundamentally important, because it sort of tips people over the edge, a certain proportion of the population. I'm going to speak to my own knowledge in post-viral autoimmune states, my own literature that we've created over decades when I was at Johns Hopkins and so on. But the way you think is the approach that I think is missing in the academic world, because they're looking at it with silos and not an integrative system. So you've heard the term system biology, of course, and live like that. And this is the way you treat patients, and I think that this is what's missing for the population. So let's get into it. I mean, I think that I did want to take one or 2 minutes to just give a very, very high level overview of where we are. I think we're about 3 years in. I think my own opinion is that COVID started certainly a few months before everyone else thought it started. And you had cases in Seattle, I believe, as early as November of 2019, probably earlier than that. And I had Silicon Valley people doing deals with the Chinese in November of 2019, and the entire room was ill with loss of taste and smell and coughs and so on. Very classical early COVID symptoms several months before it came from Europe into New York City in March of 2020. So we're in 3 years. There's a lot of lessons to be learned and to go over today. But we have 99 point some odd percent of population now exposed to Omicron versus the other variants. It is milder. It's not fun. It's not a fun experience to go through if you have symptoms, but it's not going to land you in the hospital unless you're quite old. I think the average age now is over 80, closer to 85 years of age if you're hospitalized in the United States and in the UK. But you're not going to die. It's not the same type of cytokine storm typically that we had before. So then we have the epidemic, the public health epidemic of long COVID now as the main concern for those of us that treat the iller populations and also want to protect ourselves for not having something irreversible happen to us. So we know what we know, and when you think about the system biology approach, why do you think that 95% or so of the people who end up to be hospitalized have a lot more comorbid conditions? And why is that the not only age is the predictor, but comorbid conditions are the predictors, because this virus attaches to a certain receptor that I wanted you to speak to about?
Yeah, so I think, well, thank you, by the
Yeah.
way, first off, for having me. And I think that what we're seeing with initial infection, as you said, is in the era of Omicron, unless you're already very ill or maybe elderly or a lot of comorbidities, you're very unlikely to wind up in the hospital like we saw previously, certainly. But I think that what we're seeing now is sort of a greater unmasking of how insidious the process of SARS-CoV-2 is when it infects people, because we're not getting the larger numbers of people maybe going to hospitals, maybe being in ICU, et cetera, and yet we have more penetration of the virus. We're seeing what it's doing, which what I try and tell patients is COVID is the great unmasker of anything that you may have never known you've had, or maybe knew you had it. And I think that a lot of, especially when you get to long COVID, I think a lot of the problem there is really that people don't realize how much their body is putting up with and how much you're compensating for subclinical illness. And then that becomes, superclinical illness after COVID. But I do think in the era of the acute COVID experience, when you have something that can bind to receptors like ACE2, and when you have a virus that can alter cytokines the way that COVID does, just though, and there's so many other reasons it's pathogenic, but just those two things alone create so much immunologic confusion that then if you did have, especially with Delta and prior, if you did have underlying respiratory or cardiac disease or diabetes, metabolic syndrome, any of those things, which all have a lot of things in common in some cases, the immune dysregulation just would spiral out of control. And because at least, we think back maybe 2 to 3 years ago, early treatment was not very popular. You weren't supposed to talk about it, all of that stuff. But what I think people like you and I have found is the earlier we treat people, the less trouble we have, and also the less post-COVID we have. So I think a lot of it is just an artifact of, we have this, not new, but semi-unique virus. We had original SARS, which distinguished itself because it killed people rapidly. So the spread was much more controllable. And then we have its, downstream grandchild of SARS-CoV-2, which, although it's part of the coronavirus family, it has these very unique pathogenic triggers. And those happen to be things that push on, when you push on one cytokine pathway or one receptor, you get any number of downstream things being turned on and off. And the problem that we have, in immunology is it's not a one-to-one relationship. So in a very healthy person, the trigger might go in and it may just sort of fizzle out because the body compensates. In somebody with an underlying issue, whether they know they have it or not, you might turn on those triggers, and then that actually accentuates your pathology. So then your acute experience could be worse or not, or your chronic experience could be worse. Yeah.
I think the brilliant thing you said, amongst many, but is that you said it's unmasking how much your body's tolerating on a day-to-day basis, that then it's certainly unmasking it. So this is a 50-year problem. I mean, I think a bit older than you, but when we first started practicing, I gave grand rounds at the Albert Einstein College of Medicine and Pathology on the rare disease called Alzheimer's disease in 1980. So more than 40 years ago, it was a rare. I mean, it wasn't the most common case. It was a woman in her 60s, but it was rare. And the other case I did was an autoimmune case, because the autoimmune people, the immunologists, rheumatologists were like the Maytag people. They had nothing to do, because the cardiologists and were making the majority of the dollars for the hospital in those days, and that's changed. So a lot of socioeconomic factors plug in, but it's quite interesting how you can take a fairly strong hit to your receptor, in this case, that modulates so many different functions, including immunological function, and a subset goes into a state which I call chaos, immunological chaos, and that gets all the press. But I think, knew from the beginning that there would be a much larger population that goes into a state of perpetuation. And then a state of even people who do well early, that have either no symptoms or few symptoms, and then exacerbate a state of sort of subclinical immune dysfunction. We can call it perhaps autoimmunity, with different types of mechanisms, and then they get sick. But it's slow, methodical. When I was in the transplant team at Johns Hopkins, we had folks with myocarditis, and now the public now understands that myocarditis is a real issue after this particular virus. But in those days, we had more people studying viral myocarditis than actually had it. Because it was a rare disease, but it was a good model, because you had people with fulminant disease, which was rare, but you could have that and you can end up in the ICU right away. Or you can have some kind of stomach flu, and then it attacks the heart and you get some injury, and you can measure it, and you could follow those people through, and they typically get better on their own. And then you had this group where, you may or may never have a flu-like illness, and then they just manifesting when they get really ill. And I predicted that it would take at least a year or two for that to manifest, and now it's happening, because this is certainly the biggest example of a virus producing heart injury, as we'll discuss later in the talk, as to how many people and who's getting it and so on. But we now have the NIH's attention and the government's attention for long COVID, and I'm not sure that there's a great distinguishing feature between long COVID and long vaccine. I'm not sure that it really makes that much of a difference in this case, because of the nature of the vaccines can generate their own spike proteins, and then they could generate their own autoimmune state or this dysregulated state. It doesn't have to be autoimmune. It doesn't have to be specific to a given target. But having said that, you I think understand more than many doctors out there, many master practitioners out there. If you have something that produces over 200 symptoms, that's confusing to the public. I mean, how is that possible? And it's certainly confusing to the allopathic physicians. Like, how is that possible? I mean, well, if you have a cellular defect that involves every cell of the body, perhaps that's a unifying hypothesis. Perhaps that's it. And so, why don't you speak a little bit to why you think that this may be an unmasking of a set of injuries on the cellular level that really caused this thing to go out of control in any number of people now, certainly in the tens of millions of people that are now having some degree of long COVID.
Yeah, I think just to put a point on something you brought up, and I've been doing long COVID updates now for 2 years,
Right.
which seems crazy, but I do not see this being not a problem for the rest of our careers, really. And one of the things in later reviews that I brought up, because I'll update my data summaries, and I do literature reviews, so I'm coming from someplace somewhat solid, is I just tell the physicians, whoever's in the course, that it really doesn't matter at the point that you have an injured patient, whether it was triggered through a vaccine injury or through native COVID or maybe some combination, because really the damage is the same. And so you're on the other side, you have to step back and treat this person in a more, as you say, system biology or holistic manner, or you're never really going to get them very far. And one of the frustrating things I think we see with patients is, what is the allopathic system works really good if you have one organic problem. And so what happens, long COVID patient will be referred to the cardiologist, they'll be referred to, a number of other specialists, and they'll say, well, we don't find any organic damage. So you don't need one of a cardiologist or whatever, or maybe they do find something, but then there's 11 other things that are wrong. And I think that what we're seeing, and I've seen it myself, and certainly I keep in touch with a fairly large group of clinicians who have been treating acute COVID and now who are treating long COVID. And so it's not just, what I'm seeing, I kind of compare notes. I think that regardless of the trigger, whether it's from treatment or from the infection or both, one of the things that we see in the data is the first thing they started to do a lot of research on was co-infection along with COVID-19, SARS-CoV-2. And that started way back in Wuhan. So I did some updates early on IV vitamin C and ICU use, and I published a paper on teaching American hospitals how to use vitamin C for ICU use, and a few did, not very many. But I also got all the data from Wuhan, not just on their IVC program, but on their other research, and they were already researching co-infections. And really, just to shorten up, probably what is 30 or 40 peer-reviewed papers now, maybe 50, is it's not so much, and you know how when you're researching, we like to find one answer to one problem. Anytime you look for infections with a sick COVID patient, or now look at post-COVID and you look for other infections that aren't SARS-CoV-2, you will find them. And whatever you look for, you'll find a lot of. And so we see not just, the typical things like Epstein Barr and CMV and mycoplasma pneumonia and chlamydia pneumonia, but there's a large number of very, very nasty kind of rare bacteria, a lot of them that cause pneumonias and other problems. There's fungus, there's parasites, et cetera. So I think if we look at that as that was like an early model, and that was very clear in the early data, and the sicker patients had the worst co-infections. Most of them didn't really probably gain those infections with the COVID. The COVID messed with their deranged immune system. They were either exposed acutely in the hospital, or we carry a lot of these things around in small numbers. The derangement for the COVID immune response lets these just fulminate. And I've literally had patients where they had to go to the hospital. This was with earlier variants, and they died of co-infections, not for lack of knowledge, but lack of the attending staff not calling infectious disease soon enough to test for them. And in every case, infectious disease always said, well, we wish you would have brought us in earlier, because they actually died of these other infections, and we could have probably treated them. But I think the more important thing is, because it's kind of easy to take the ball and run towards infections because it makes sense. But the other areas that we're starting to see more and more data on are reactivation or de novo activation of autoimmunity,
Right.
probably from the same triggers, um, increased sensitivity to environmental toxins. So we now see people who maybe were tolerating mycotoxin mold exposure fine. They didn't know it was a problem. They come out the other side of COVID, and the mold exposure doesn't change, but their tolerance drops.
Changes.
And I've seen the same with metals and environmental chemicals, et cetera. So there's a big environmental piece. And none of us, well, you and I might, but most people in the public don't want to think about how toxic the world is around them. And we don't realize, what a soup of immune disrupting chemicals that we live in. And so that's a whole other area. And the other one that I think is real insidious, and people don't test for it till often it's maybe too far gone. Well, not too far gone, but pretty bad, is there's a lot of early on subtle and then later less subtle endocrine disruption. So in our normal response to cytokines shifting around, our adrenals will produce a bit more cortisol, and they'll shift things around to mitigate the immune response, and our thyroid responds to that. A lot of these folks will come out the other side. They never had any endocrine problems, and now they've developed thyroid resistance or either hyper or hypocortisol output, all that kind of thing. And I think that if we don't, and I always will tell the doctors this in the audience, of course, this is a small, medium, and large problem. So if it's a small problem, you can probably get them past it fairly easily. But people with medium and large, pathologies in post-COVID especially, they really require all these systems to be rechecked, and in spite of how healthy the person might have felt they were prior. And I think that that's why I feel COVID's initial immune disruption, or maybe spike protein triggered by the vaccine initial immune disruption, is just so good at twisting the immune response just enough that it opens the door to all these things that are possible.
Well, thank you for that really nice explanation. To me, it brings up the following type of thinking. The concept of we're living like an area under the curve in terms of toxins. Okay, so the last time we had a definitive type of very large scale epidemic was in the flu in the Spanish, in the flu epidemic of 1918, I think, 1919. And well, what was different about that? Well, it killed a lot of people. We knew that, both children and adults, and we are thankfully protected here as children with a particular mechanism of action of the virus. Because the younger you are, the more likely you haven't messed up your ACE2 receptor as much as us adults have. But we didn't have industrialization, and our population was so much smaller. Now, we lived in dirtier conditions. We did, and we had no access to antibiotics and so on. But we had access to better food quality, less chemicals and less toxins, and probably fresher water. Who knows? But we have better public health conditions now, but environmental conditions are bad. And as you well know, and we can talk about later, the effect on gut immunity is fundamental to our overall health, and this subverts that again and uses it against us, because it does push us towards autoimmune states in a natural way. So you have these. We changed, and I sort of sensed that when I was in high school and university, that by the time I got into medical school and training 10 years later, things had begun to shift, and probably that's in the late 70s and early 80s, and industrialization started taking form. And so this is the great unmasker. I like that term. I think it's a great term to use. So, but then you say it doesn't really matter how you get here, because we've been here before. We've been, and I got trained in medicine in Yale, and very close to Lyme country there, and never heard of it. I just didn't hear about it. Actually, the last doctors to ever treat people were in Connecticut, but it started there. But we have chronic fatigue syndromes, the encephalitises, and so on. We know what they look like, and they look quite similar. And you pick that up in whether you're reading. It's not, you don't pick that up so much by reading the New England Journal as you do reading the New York Times and the Atlantic magazine, which is now my favorite news source for information on COVID and long COVID, and Vanity Fair, because they're picking up the individual stories and saying, well, wait a second, this reminds me, I've had this for 20 years. I've been a chronic persistent Lyme patient for 20 years. And now after my COVID, I'm worse, and I'm reactivating, or I'm reactivating the persistent cells or whatever it is. But I've had this for a long time, and I've been treated like it's a psychiatric condition for a long time. But guess what? It isn't. And so this takes the COVID wars, make the Lyme wars look silly, relatively speaking, but it exposes that reality where if you're looking for a single cause for something that produces an exponential number of disorders, you're not looking, you can't see it that way, because it doesn't make sense for people who want to look at it that way. So we have something that needs to be treated a certain way. So you brought up the issue of IVs, and of course, if you have someone with acute COVID infection, we have tools at our disposal in the naturopathic world or in the integrative medicine and functional medicine world that we know should help and will certainly not make anyone worse. It's not wait until you can't breathe and then come to the emergency room. That wasn't a rational approach. We all know that. So, but they're basically metabolically get you back to metabolic shape. It's things that in principle bring your antioxidant systems up and bring your inflammatory system under control. Can you speak to that a little bit and say that's in the acute situation? Then we'll go further into where you are and what it exposed and how you can learn and who to see to get that mystery solved for all these millions of types of people that need to know.
Yeah. I truly think in starting with the acute illness with COVID-19. What I have seen over and over, and what I've seen with many, many other clinicians in this group that we compare notes with, is as opposed to what you had mentioned, the original advice, which was stay home till you can't breathe and then go to the hospital, which is just a recipe for disaster, as we saw. If we could do more aggressive things early in the illness, much like we would do with any other acute viremia that we might see, et cetera, we had a much shorter duration of the illness. Those patients didn't go to the hospital. They didn't need to. And the majority of them didn't experience long COVID. And so that in my practice, if I could get the person, even when they were early and febrile, and we gave them a high dose vitamin C, IV, provided all the labs were okay, the earlier we could do that, the better. Same with ozone, same with, just whatever was clinically appropriate. And then the other things that we saw that kind of fit into the same line of thinking with a good outcome was if we did things that not only supported the immune system and the oxidation reduction part of the immune system, which gets really hit hard with COVID early, but if we also supported not allowing all of those potential co-infections to fulminate or come out, we had much shorter duration of illness and healthier patients on the other end. The one change that I have seen during the era of Omicron is because it's, as you said earlier, it's an uncomfortable illness, but it generally isn't going to send you to the hospital, et cetera. If they started to, get a pretty bad viremia for a few days, but then they started to improve at about day 3 or 4. If they had a second wave, that was always caused by other infections. And so the initial few days weaken the system, gets the immune chemistry all, out of balance. Body can't, correct itself. The second wave is usually non-COVID based infections. And so that's why we're really aggressive with them on that end. The other thing I think that's important, just to get the IV vitamin C idea, there's really sort of two procedures that were done. One was pre-hospital higher doses, as I said, maybe 50 or 75 grams of vitamin C, or a really good, ozone dose, et cetera, or maybe alternate. In the hospital, with a couple exceptions, so there were the original Wuhan case reports. We've got 2 RCTs finally published with positive response in the ICU, and there's more RCTs that are somewhere in the publication process. What they noticed worked better was a continuous infusion of vitamin C, so that their body was getting about a gram an hour. They give them 24 grams in 24 hours on a pump. And the reason, and it would lower IL-6, it wouldn't snuff IL-6 out, but it would bring IL-6 down to a more moderatable level. It manipulated some other cytokines, and these people were, everyone who was in the trial with the drug, with the vitamin C, shorter hospital duration, survival benefit, and some biochemistry benefit. So it would seem that when they got to the hospital, a kind of a continuous low and slow with the ascorbate, because we all know that when we're ill acutely, our ascorbate just drops to 0 because it's water soluble and we can't get enough. And that not only throws off your primary immune cells and primary immune function, but it takes away the whole center of your oxidative reductive balance. So if your cytokines are spiraling out of control, and we take the middle of your redox control out with vitamin C drop, and our body can't do its normal thing and go in and kind of calm the cytokines down. So I think that's why that worked. I will say that there's one case report from Wuhan where someone was literally dying, and they thought, well, let's just try something. They gave him 50 grams very rapidly, more like we do outside the hospital. And that person actually got off the ventilator and lived, which was quite a story in and of itself. So, and I've seen that. And as I mentioned, we published a paper for hospitals, because you'd call the hospital ICU and they'd say, well, we've never given IV vitamin C, or we've heard about it. So we published this paper that has very clear, easy to do. It's got instructions for nursing and pharmacy and the ICU docs. And in the few cases where I think families probably threatened to sue, where we did that early in with the bad variants early on, we didn't have any patient who wasn't able to get off the ventilator and leave the hospital, which was pretty amazing, regardless of issues. So I think that, earlier treatment, early on, everyone was, for whatever reason, we were all told, well, don't say anyone, don't tell anyone you're doing early treatment. We don't know what it is. Don't tell anyone you know what it is. So it was just like, well, let's just treat you anyway. But I think everybody's seen that is a pathway to not only more live patients, but healthier patients on the other end when you get to long COVID.
And another fundamental observation was that the trend to people with higher vitamin D levels will also do better and will be better later on as well. So it goes to cellular functions that need to be sort of in certain types of balances that are just thrown out of balance. And then if you put it back in balance, in this case, vitamin C is doing a lot of things, but it's also a virus killer. So you're also reducing the viral load if you get there in the first few days.
Yeah.
I think our observation is similar to what you said in the sense that the second wave of day 4, 5, and 6 after Omicron, it's the folks that have other co-infections or biotoxins like mold. So that they're getting that. And in California and San Francisco, where we're based, there's a lot of mold, and people had. So there was a certain group of people that hadn't gotten COVID yet, but were indoors all day and got exposed to more. They never left the apartment, so they got exposed to more of their mold. And then there were patients who, clients who got COVID or got vaccinated and so on, and then became sensitive for the first time to the mold that they had already been exposed to. And you all know that there's somewhat of a genetic risk as well, and for susceptibility, and like we have for almost every illness. And so it tops. You could say that those people are more at risk, but you can have a couple living in the same location or entire family, and only one person getting the real exposure that bothers them enough that other things pop out. Um, we are some of the unhealthiest people on earth, um, as you also know, and so I think with the NIH's own data, as you know, more than 90% of us have metabolic dysfunction. So, and then you said later on in the course of the folks that get iller later and have more problems, that you have a lot of metabolic dysfunction that you can measure. And so let's talk about first, like what we can measure and what typically comes out of these folks, and then out of that maybe what kind of generalized type of principles of treatment. Because ultimately, I thought this would be a real push. COVID would be a real push to see your naturopathic doctor and see your integrative doctor, and maybe that's going to happen over time. But I don't think the public is educated enough in this area. Not yet. It can never be enough. But your comments should be stunning to the public, and that is that you are convinced, as a master of doing this for more than 3 decades, that we're going to be left with this for the rest of our lives. And I have the same opinion. So when we unearthed the last great unmasker was industrialization, industrial food supply, technology, big tobacco, big pharma, big blank. And that unearthed, took something again, like something that would normally take maybe a fraction of 1% of the population would manifest an illness, to maybe 4 or 5% of the population would be at risk to get something serious out of day-to-day life, basically, or they get exposed to an influenza virus or EB virus or cytomegalovirus or something like that most of us have in our system, but would get ill. And now it's 40% of the population, because things are fundamentally different. So what do you envision now that most people can get their vitamin D levels paid for by insurance, to be covered in most institutions, and most doctors would get it? What do you think people should be looking for? Should they be looking for changes in the way they handle sugar metabolism? And should there be ways that they're looking what their antioxidant status is? I think that's something that you could talk to specifically.
Yeah, I think you bring up so many good starting points there. I think, as you mentioned, the vitamin D levels and correlation with severity of illness and death and everything. We started to get those papers coming out, kind of a little bit later, but fairly early. And people, would push back on that and say, well, it can't make that much difference. And it really does. And it's a fairly simple thing to do. And as you mentioned, most of the time it would be covered just to check and find out where you're at. What we try to get our patients to do is to get their vitamin D levels in the upper quartile, so the upper 25% of the normal range. Even though that's a little higher than some of the data that showed just associations with less disease, there's a lot of other good reasons for that. Now, one of the things I think that makes it maybe better in a more complicated patient situation to see someone like us in the integrative and naturopathic world is when you get to a lot of the chronic pro-inflammatory things, such as metabolic disruption that we'll talk about next, you can also get derangement in your vitamin D metabolism. And so sometimes what will happen is people will go and they'll get it rechecked at 3 months or 6 months. And it's like, geez, I'm taking all this vitamin D and it's
Yes.
still low. Well, what's happening is the inflammatory part of their biology is actually triggering the hydroxylase enzymes to convert it downstream to a less desired isomer of vitamin D. And so really underneath all of this, especially when you get to long COVID, you're bringing up metabolic dysfunction and how that bleeds over into, our antioxidants, et cetera. That's, I think, ground zero for what you could say lights the fire.
Yes.
And so, again, there are so many people, when we talk about industrial age and also, industrialized food, and the American diet generally being completely unhealthy for many people. Well, the same way we got people who didn't notice mold before and now they do now, we could add people with dysglycemia, insulin resistance, pre-diabetes, or even frank type 2 diabetes who didn't know before.
Yes.
Then they go and they get this big triggering event through whichever pathway you trigger it. And when you have insulin dysregulation, which is, large part diet, part genetics, and then, part other things, it is one of the biggest chronic 24 hours a day, 7 days a week triggers of abnormal inflammatory chemistry in your body. Well, if you get this virus, it has this oddball twist to its, inflammatory chemistry. My body then is already churning, all this low-level inflammation. It just pushes you further into the negative part of the inflammatory response because, we want the inflammatory response early on to trigger our immune system. But normally our body has countermeasures to bring it down. When you have metabolic dysfunction and then you get the right mixture of inflammatory chemistry from an infection, the infection can just spiral out of control. And I think, especially in the earlier variants, that's why we saw people with metabolic dysfunction, high BMIs, cardiovascular disease, they would be more likely to get much more sick. Right. It's the one unifying pathology there underneath everything. And I think that we don't it's certainly in the medical data, but we don't really talk about, we don't realize, maybe especially as the public, how unrelenting metabolic dysfunction is because we don't feel it usually.
Right.
And then so underneath, it's just sitting there, just, hammering away on you in an inflammatory manner. So not only does it derange your normal antioxidants, all that, if you get sick, your body has a real hard time bringing you back to, neutral, bringing you back to health. So I think that metabolic dysfunction is another thing that really needs to be looked at and can exacerbate when you get into long COVID. So looking at, the basics like C-peptides and fasting insulin and A1Cs and, all those things that we like to track. The other thing that I'm seeing that is identifiable and quantifiable that I think at least in the right population should be tracked are the LDL subfractions and a lot of the little inflammatory chemical markers we can look at with respect to cardiovascular health. And what I've been seeing in the people, usually it's people that had pre-existing lipid issues, or maybe they had, other health issues, but we do an NMR, for example, and fractionate out their LDLs and their lipoproteins and things. They'll often be much more inflamed than they were prior to COVID or prior to the vaccine, et cetera. And so the small particle size will go up, and the LPA will shift, and the like protein Bs will go up. And so they just pick on this even more inflammatory chemistry. And what I'll try and get across to the patient is that while there are many things to do about this, what this means is it's not just your cholesterol that's the thing we can look
Right.
at. Every cell membrane in your body doesn't have a chance to quell inflammatory activity now,
Right.
because it's so inflamed. So, things like vitamin D, well beyond bone health, vitamin D is one of the master immunologic regulators in the body, which is probably why it's associated with better health in this infection, certainly. Vitamin C on a different tack, same idea, albeit easier to use up, and it kind of goes through you faster, so you have to keep replacing that one. But I really think that this underlying inflammatory biology, a lot of which we can test much better than we used to be able to, I think that is part of what's at the base. And then we keep bringing up the angiotensin converting enzyme, the ACE2 receptor, and we're trained to think of that with respect to sodium potassium
Right.
balance, and certainly it does that. But the ACE receptors are all over, and they're also involved in things way beyond electrolyte shifting and keeping us from having electrolyte shifts that kill us, etc. And so they're part of what deranges your adrenal function, which is so critical for calming your inflammatory response. They derange many other endocrine and many other tissue areas. So I think that when you're looking at getting the genie back in the bottle with respect to long COVID, that's where you kind of have to take a step back and say, well, let's start with the obvious things. So a person has some metabolic dysfunction, they're very inflamed. We've got some data points we can look at, and maybe their endocrine system's just a little off balance. We can work on that. If that's pushing them forward by working on those things, then we kind of leave well enough alone and see how they resolve. If we do all that and they're still just, they have that chronic fatigue picture, that chronic Lyme picture that's not going away, I always tell people, let's take a look at infections they do or don't know they have. So let's do something broad there. We will often, in everybody now for screening, will rerun anti-nuclear antibodies, because those can kick up after thyroid antibodies can. And so then we just start to broaden our look. And that would include the environmental stuff we already talked about.
Well, thanks again for that great summary. I think we're going to add the coagulation markers to that list as well, certainly in someone with any vascular pathology and vascular tendency. The D dimer is the one that we typically use. We can talk about that in a few minutes, but also we look at ferritin, serum ferritin, as an iron marker, but to me it's a rust marker. So it's oxidized iron that's running around. So you want to keep your ferritin level on the low side too. But the concept of if you get hit with an acute virus of this type of magnitude that has an effect on sort of a global effect, you're going to go into an inflammatory state more likely. This is not necessarily captain of the football team at the age of 17, but for the adults, when you look at the epidemiology, 80% of all the U.S. deaths, at least in the old days, in the first year and a half or 2 years of COVID, are in greater than 65 years of age. And I mean, the risk is hundreds times less in the children. I mean, just an enormous factor less. But you have, so you get this hit to your system. It's going to be a lot of hard work to get back to where you were before, but the where you were before put you in this mess in the first place. So if you that's the message, the real message here, that you thought you're okay, but you're still aging in an accelerated fashion, and now that acceleration is now in an extra gear. So you're working on that even more towards a negative effect. This is not the people who are dying suddenly, who have thrombus or clots, heart clots and brain clots and clots in their venous systems and so on. But these are the folks that are just inflammatory. So the inflammasome is now becoming more and more known to the general public. Well, it's not good to be inflammatory, but we live that lifestyle, and now it's the kimono is open, basically. So it's a lot of work, and so it's not easy it's much easier to get to a destination when the train is going downhill, because you don't have to use a lot of gas, but to get there, a lot of electricity or coal. But it's really hard to slow it down. Now, everybody gets a lot of attention on social media by saying, "Oh, well, we're all going to live forever now, and I'm going to be a centenarian like my next door neighbor is, and 90 is going to. The new one is 90 is the new 40." Okay. Well, if you pass this immunological metabolic dysfunction stress test, then maybe you're on track. Maybe you are, at least in this particular way. It doesn't mean you can't get the flu next season and die from it. It's possible, because that's maybe something unique to you, but your whole system is sort of stable, But if you fail it, that's a signal that your body's saying on a whole global level, you have to fix me. So sometimes it takes IV therapy. Sometimes it takes, ozone. Sometimes now we have, as you know, you're the founder of AAMP, and I'm the president of ACAM, one of the, I guess, in the 49th year of their life. But we have one whole day on more advanced ozone therapy called EBOO, which puts a filtration system onto the ozone. And why is that important? Well, it's not important for the average person per se, but it's become important because some people will require it in order to get over long COVID. Some people will. And it's not the only thing in the toolbox that you're going to have to use. You have to fix a lot of the systems to get it back to a state of homeostasis. So, I think that the basics are still the basics, and naturopaths are so good at it. So it's take your walk every day after dinner. So it's exercise, it's time restricted eating, it's vitamin D, it's getting your glucose metabolism not to be carbohydrate overloaded, and getting your antioxidant system up with something as simple as taking vitamin C. It's not so profoundly difficult, but when you're out of whack, to understand that is a true signal. That is a signal. I mean, and it's an important one. I did a study before I started Anatara medicine 11 years ago, and I asked one of the world's largest databases to look at people that had Alzheimer's then, in the current time, and look at their records back 25 years earlier. And what they found was it didn't matter what the symptoms really were, but they had a list that was 2.5 times their age and sex matched controls that didn't have Alzheimer's. So they had all these signals going on, and said, okay, these are nuisance things. There's nuisances but they're not important. But meanwhile, they do have overall an effect. And as you know, and you could speak to a little bit, we have a lot of the press going on that one of the most common long COVID symptom is probably brain fog, and that's brain inflammation from whatever cause. It just whether it's reactivation of something you had before, or it's related to the virus or the vaccines, but it's a state of a low grade inflammation. You can have the same in the heart. These are the two most common that sort of come up, and they're serious enough to get everyone's attention. But you're inflammatory, so surprise. And what my younger son is is graduating from Johns Hopkins this next month, and he was a public health major before COVID, and now he's in an economics major because he switched majors because he sort of said, like, wait a second, is this really public health or is it infectious disease control? Is it what do we have here? And we need a massive educational set of programs that talk about, this is how to live your life a little bit more cleanly, and you have to decide what's worth it and what isn't worth it. But you should at least be educated onto this. So I think naturopathic medicine should be part of allopathic medicine training. You have my complete support with that. I think it's truly missing from our education and our public's education. We've been going on about an hour now, Paul, and do you have any sort of closing statements? I think we have a lot of tools in the toolbox that the public is not aware of. I do want to make one more comment. You've had NIH grants, and I've had many NIH grants in the past and participated in many clinical trials. And we all know now that in most of the big cities in the country, the major academic institutions have long COVID clinics. And when you go there, they do have you seen by the appropriate set of specialists. But when you look at the NIH's structure, the way they go about handling a problem like this is they accumulate data, and they'll study and observe, and then they'll store bloods and so on for future studies and so on. And one of the problems with that, when there's no hypotheses being tested, is that we'll see you later in 2025 when we get a hold of all the information that we've accumulated over the last 3 years, because now it takes 3 years to accumulate it, to get enough people on it. But then we'll get to the hypotheses, and that's not going to work here. It's just the public cannot wait another 2.5, 3 years to hear what they're going to be measuring in the next set of trials, because you know that this fits into a hypothetical framework which deals with inflammation and mitochondrial dysfunction as the end pathology, and we know there are basic principles that could be followed.
Yeah, I mean, there's so much that could be unpacked there, but just a couple of things I think to summarize that I've seen and seen have correlation. One is what you brought up earlier. We follow these other inflammatory markers in these patients, and so CRPs and D-dimers and ferritins and LDH and some other markers that are considered soft, but they're very meaningful. And normally there will be some in that group that will be elevated. And one of the frustrating things, I just did a post-COVID update for a state association, and they were sending me questions to sort of work off of. And one of them was they kept trying to treat the D-dimer and, or go after the particular analyte. And what I told them was, I said, when it gets to long COVID especially, those things are your immunome's way of speaking back to you that you're just inflamed, and it could be high ferritin, it could be D-dimer, it could be all of them. And I said, really, you watch those, but they will not become normalized until you treat the rest of the person. That the rest of the person is what's making those go up, because we think the other way. We think, well, there's no clot dissolving, so why is the D-dimer high and all this? Well, it's because we're super inflamed. Same with the ferritin. So I think that's a big mind shift, which is, instead of treating those numbers, we have to make the patient better, make their inflammasome come down and level out. Then those things take care of themselves. The other thing that is in the data, I mean, there's close to 100 really wide-ranging just neurological injury and COVID papers. And most of them come up, especially the ones in the last year, with the same thesis. which is with absolutely no physical trauma, COVID is exactly the same as a high force TBI,
Yes.
traumatic brain injury. And so no one's looking for that. No one's looking to treat that. Well, the brain is so inflamed that the blood-brain barrier is leaky and the neurotransmitters don't regulate right. And the brain's just constantly inflamed, which is a big part of where the brain fog and the central pain comes from. A lot like we see in our Lyme patients or other
Yes.
people like that. Um, and so that's another thing, like getting that in doctors' heads that okay, no trauma, but we have the same level of derangement
Yes.
of brain function just by the COVID event, for example. So I think that it's sort of getting people to take a step back, which, so yes, in the integrative and naturopathic community, that's sort of how we're supposed to think about things. In the allopathic community, it's much harder because they're looking for, one cause, one treatment, and we all know like that's never going to happen, especially with long COVID.
Right.
And so until NIH and other places start considering it that way, I know many people are helped by these long COVID clinics, but a lot of times it's just the revolving door of specialists ruling things out and saying, well, you don't have my problem. Uh, and really they have a bigger problem. So I do think the idea of the inflammasome and metabolic health and all of that, that's sort of really at the ground floor of a lot of where the trouble is. The one thing I would, and this is just my better angels speaking, they've been very quiet the last 3 years, my better angels, but when we started our study that NIH funded for integrative oncology, it was, I think, one of the first whole practice studies. So we collaborated with Seattle Cancer Care Alliance, so real, high-powered folks. Our part was, would an integrative approach to a person with cancer, and in my part of it was all stage 4, but would an integrative approach that looked at all these other things that you and I are talking about now improve overall survival and quality of life?
Right.
And everyone thought it would do nothing. And we had enough signal on that with survival and some quality of life that a follow-up study was funded to look specifically at 4 of the more common cancers, and and that's winding up sometime soon, I think. So my hope would be with long COVID that, somehow NIH would be open to a whole practice study, which is what you and I do. And I think that's the only way out of long COVID.
Well, that I think will be part of your legacy. And I do think part of your legacy is educating hundreds of practitioners. So can you just give us 1 minute on what you're going to be doing at AAMP this next year?
Yeah, so advanced applications in medical practice. We do 2 3-day CMEs a year. They're AMA category 1. And what my goal, I'm the curriculum part of it. So my goal is to usually have 4 or 5 people with specialty areas join me. And so we don't have a lot of speakers, we have a lot of depth. And we pick topics that generally are, things in the integrative world that people are concerned with. The reason that the spring one coming up in May 2023, I decided to do mitochondrial dysfunction and healing in the age of long COVID is I knew long COVID wasn't going away. And I also know that a lot of the repair has to start at this very base mitochondrial and cellular level. And I think beyond mitochondrial diseases that you might see at a children's hospital or something like that, there's so many mitochondrial damage scenarios, and there's genetic things that get turned on during illness that damage the mitochondria. And we're really just now in an era where we can test them more accurately to figure out where the problem is. So I do think that that's going to be kind of the next step or the next level that we all need to be looking at and seeing if our patients are really healing. Is are we doing the right thing for these base parts of our cellular apparatus, which are so damaged by all the things we talked about? So that's our spring conference. And of course, it's not just long COVID. It would relate to our Lyme patients and chronic fatigue and everybody else, really. And then normally every 2 years we do an oncology focused meeting, and that will be in the fall of 2023. We're working on faculty for both of those right now, so it's exciting, and it gives me a chance to reach out and talk to experts and get them to come in and be helpful to educating doctors.
Well, thank you for that, and I think you'll be seeing me at both of the conferences, so we'll be able to greet each other again. And I think the whether you're trying to treat a world class athlete or someone with stage 4 cancer or anyone in between with acute or chronic COVID infection, we learn from every patient. So it's the summation of all the learnings from all these different sort of types of folks that gives you, I think, the knowledge that ultimately leads to a master practitioner that's been out of medical school for more than 2 years. So thank you very much, Paul, again, for your time and for your company.
Thank you so much.